Hello everyone, my name is Rick Landis with Landis Emergency Training Services, better known as L.E.T.S Training. Our company focuses on high quality education by providing you with instructors who are active or retired firefighters and paramedics with over 60 years of experience. By reviewing this PowerPoint presentation, you will be prepared to pass your ACLS skills with ease. You will want to watch this presentation as many times as you need in order to be ready to run an ACLS Megacode during your skills session. Because we only have 1 hour to get through all 6 students during class, it is imperative that you become familiar with the material provided in this presentation to pass your skills test. We look forward to seeing everyone in class and wish you all the best during these difficult times. Stay healthy and safe. We will see you soon.
Hi, my name's Rocky. I'm one of the ACLS instructors that's going to be helping you through your Megacodes. And we basically wanted to take a minute, nice relaxed video, kind of go through what's expected of you when you step up to do your Megacode. You're going to receive a Zoom invitation in your email at a scheduled time. So you will come into the Zoom meeting where you will see 5 other students beside yourself and your instructor. So in the Zoom meeting, you'll all come together, you'll all be able to talk, you'll all help each other through the Megacode. So it's not just one person while the other 5 sit there. Each of you will take a position. So if you can imagine, if you come on and there's 6 of you, one's the lead, one does compressions, one does the airway, one does meds, one does the monitor, and then one is the recorder. Now, you'll talk and you'll work together, much like you would see on the team dynamics video on AHA. And if you ever want to go back and take a look at that, you can go on YouTube and just look up AHA Team Dynamics ACLS. If you watch that video, that is the Megacode. That's exactly what you're going to do. So everybody comes in, they're either a really fast rhythm or they're a really slow rhythm. So for your Megacode, everyone's unstable. They're all either going to be fast or slow, then they're going to go into VFib, then from VFib we'll work to PEA Asystole and then to ROSC. But the thing is, you're going to have to identify it and you're going to have to treat it. So what can we do to help you treat these patients and identify this stuff and make you proficient at ACLS? So again, the Megacode, fast or slow, ventricular fib, PEA Asystole, ROSC. That's the flow. Go back and watch the team dynamics video. But we're going to give you an example at the end as well. So if you're not a rhythm expert, that's okay. So we're going to simplify this for you. When you look at a rhythm, if all the patients are unstable, it's either going to be narrow, wide, fast, or slow. If you can identify that, if it's wide, you know it's ventricular in origin, so like a VTAC, or a third degree heart block is going to have a wider QRS complex, versus something really fast that's narrow. Okay, so you've got your SVTs, rapid AFib. Does it really matter? We don't have to worry about the adenosine and things like that because your Megacode, everyone's unstable. So whether it's VTAC or an SVT, here's the best part. It's all treated the same. So we're going to cardiovert at 100 joules. We're not going to start at 50. We're just going to keep this simple. We're going to cardiovert at 100 joules. So now stick with me here and let's go through this. So you'll come up, your instructor will say, you have a 70-year-old male, pale, cool, and clammy, feeling like he's about to faint. Now, in your Zoom meeting, you're going to see a presentation that's actually going to be your monitor. And here's an example of that monitor. Each of you are going to be in this Zoom meeting for the Megacode. Each of you will take a position. Now, who's ever in charge, basically the Megacode will start something like this. Your instructor is going to say, you have a 70-year-old male, pale, cool, and clammy, feeling like he's about to faint. So you don't know any other information from that. The monitor is not going to show anything yet. So basically the first words out of your mouth need to be, and write this down, movie, M-O-V-I-E. monitor, O2, vitals, IV, and exam, movie. So if I were in charge, I would step up and you hear 70-year-old male, pale, cool, and clammy, feeling like they're about to faint. Okay, I want the monitor, I want O2, I want vital signs, I need an IV, and let's examine the patient. Sir, what's going on today? That should be the first thing you say. So, oh man, I don't know. I just haven't been feeling well. I'm not doing well. I have this slow heart rate thing, and man, I don't feel good. I feel like I'm going to pass out. Okay, well, that should be giving you a warning sign of a bradycardia, right? So we show up and the blood pressure is 70/30, and you're going to see on the monitor, you're going to see some type of bradycardia. Now, here's the really cool part of what we're teaching you, okay? It doesn't matter if they're in a third-degree heart block, second-degree type 1, second-degree type 2. If it's too slow, we're going to give atropine and we're going to pace the patient, right? It's as simple as that. So we'd love for each and every one of you to go, oh, that's a second-degree type 2 classic heart block. But at the end of the day, what's important is for you to treat your patient in these emergency scenarios. So if you can identify the heart rate's too slow, it's some type of bradycardia, looks like some kind of heart block, all right, let's go ahead and give 0.5 of atropine and let's prepare to pace. That's what you say, okay? So too fast or too slow, let's go too fast. Again, a fast heart rhythm is too fast, the heart can't fill, whether it's an SVT, a rapid AFib, could be a VTAC, narrow, wide, fast, or slow. Keep it simple. If it's too fast, we're going to cardiovert. So a synchronized cardioversion means we have to hit the sync button. We're hitting the sync button, so what really happens is you're sending out the shock on the R wave. So it synchronizes with that R wave, and that's when it fires. So that's why we can't use the sync button in ventricular fib, because it won't find the R wave and it would never fire. So we're turning on the sync button. We're going to charge the monitor to 100 joules. Just remember 100 or 200. Keep it simple. So again, fast or slow? Is it narrow, wide, fast, or slow? Okay, if it's too fast, we're going to cardiovert. If it's too slow, we're going to pace. So again, let's start off with this again. For your Megacode, you're in charge. The instructor is going to say, I have a 70-year-old male, pale, cool, and clammy, feeling like he's about to faint. Okay? All right, I need monitor O2, vitals, IV, and sir, what's going on today? That's your exam. Sir, what's going on today? I'm just not feeling good. I feel like I'm going to faint. Okay? So then you'll see on the screen, you'll see the actual monitor in progress. You'll see some type of bradycardia. And then you'll see the vital signs, 70/30. The pulse ox is 90. Pale, cool, and clammy. You have an unstable bradycardia. So you're going to have to pace the patient. So you put the pacer pads on, and in this process, we can also give our first drug, atropine. Now, we all know that's the purple box. We know what atropine does. If you have a problem remembering how much atropine to give, okay, I like to tell people, remember half-tropine. Half-tropine, say it with me, half-tropine. So we start off with 0.5 of half-tropine. If you want to say half-tropine, I don't care. So, but 0.5 of atropine, our max dose is 3 milligrams. So again, too slow, pale, cool, and clammy, low blood pressure, unstable, half-tropine. So we give a half milligram of atropine and prepare to pace. Now, if it's too fast, if they come up pale, cool, and clammy, feeling like they're about to faint, but they have palpitations. I've been feeling my chest is racing. Too fast. If it's narrow or wide, we're just going to cardiovert it. We're going to cardiovert at 100 joules. So again, the very first part of the Megacode, they're either going to be too slow, atropine, half milligram, max dose of 3, and we're going to pace, or they're going to be too fast. we're going to synchronize cardiovert them at 100 joules. Then all of a sudden, everyone's going to go into ventricular fibrillation. Okay? So as soon as I see this, I'm going to go, oh my gosh, check for a pulse. There is no pulse. All right, you begin CPR, and when you see VFib happen in front of you immediately, you're going to need to defibrillate that right away. So we're going to say it's a biphasic monitor, and everyone's going to be defibrillated at 200 joules across the board. We're not going to be switching it around. So we're going to keep it simple at 200 joules. So again, narrow, wide, fast, and slow. Patient's going to be too slow, too fast. They're going to go into VFib. So with VFib, I want you to remember this: shock, shock, epi, shock, amiodarone. 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 Say it with me. Shock, shock, epi, shock, amiodarone. Shock, shock, epi, shock, amiodarone. Shock, shock, epi, shock, amiodarone. You know those cheat cards you guys carry with all that detailed information on it? It all comes down to shock, shock, epi, shock, amiodarone. That's all the darn card says. So if you can remember shock, shock, epi, shock, amiodarone, you're going to get this. So the patient rolls into VFib. All of a sudden, the eyes roll back in the head. Okay, let's stop. Let's check for a pulse. There is no pulse. All right, I want you to do compressions. I want number 2, I want you to be the airway. Number 3, I want you to do meds. Number 4, I want you to be on the monitor. And number 5, I want you to be the recorder. Now, this is where the interaction's really going to begin. So, whichever one of you is on compressions, okay, I'm starting compressions. Okay, I'll go ahead and bag the patient. All right, I'll be on monitor. Okay, I'll do meds. All right, and I need each of you to have a piece of paper and a pen because you're going to be the recorder for this for them. So when they go, how many have I given? You'll be able to say they've done 2 epis, you've shocked twice, So who's ever taken that recorder position, it's very important for you to work together as a team. So they went into VFib, you've started CPR. Now let's do our first shock. We're going to use a biphasic monitor only, and the monitor is represented by our graphic in the Zoom meeting, and you're going to see VFib on there. You're going to ask whoever you assign the monitor, all right, I want you to go ahead and defibrillate at 200 joules and defibrillate when you're ready. Whichever one of you is on the monitor is going to say, okay, charging to 200 joules, charging, everybody clear. Remember, you have to clear the patient. If you don't clear the patient, somebody's going to get hurt, and that's a critical fail in a Megacode. So who's ever on the monitor, it's real important to pay attention and that you say clear. Okay? Charging to 200 joules, clear the patient, everybody clear, shocking. Then who's ever in charge? Okay, let's get back onto CPR. Make sure you switch every 2 minutes. So you want your airway person and your CPR person switching every 2 minutes. That's one of those check boxes. Okay, so fast or slow, VFib, shock, shock, epi, shock, amiodarone. We've done the first shock. 2 minutes of CPR goes by, and then we have our second shock. So remember, shock, shock. But in between there, while we're waiting, one of the things you can do is, how's the airway? So ask your airway person, and the airway person should volunteer this information after the first shock to help out who's ever in charge, because they're going to be thinking of a lot of different things. So you have the first shock, you're back on the CPR, the airway person should say, the airway's good, I have good compliance, I have good chest rise, it's going really well. That's a good thing, one of those check boxes. So 2 minutes, your instructor will say 2 minutes is up. All right, and who's ever in charge is going to go, all right, let's stop CPR, let's check for a pulse. We check for a pulse at the end of 2 minutes, not after a shock. Let's check for a pulse. This is what we have on the monitor. You're going to see VFib, shock, shock. Again, everything's 200 joules, shock, shock. Okay, So I want you to go ahead and defibrillate at 200 joules. Gotcha. Charging. Okay, everybody clear. Shocking. Shock, shock. And we're doing 2 minutes of CPR in between each. Now, not really, because we got to time this through a little faster. And that's the point of this video. So shock, shock. So now that I've done 2 shocks, let's give our second Acls drug, epinephrine. Remember, epi, we give 1 milligram every 3 to 5 minutes. There is no max dose, okay? So you're going to be asked that. So we're right back onto CPR. Let's go ahead and give 1 milligram of epinephrine, and your instructor is going to say, how often can that be given? And you're going to say every 3 to 5 minutes. Is there a max dose? No, there is no max dose. And then you're going to continue. Shock, shock, epi. 2 minutes is up. You're going to check a pulse, stop CPR, make sure you switch, check a pulse. Okay? There is no pulse. You look at the monitor, you still see V-fib. We're going to shock again. Again, how much? 200. So I want you to go ahead and charge again to 200 joules and defibrillate when you're ready. Okay? Charging. 200 joules. Everyone clear. Shocking. So your monitor person does that. Shock, shock, epi, shock. What's next? Amiodarone. You have 3 vials of amiodarone, okay? Each vial is 150 milligrams. So if you have 3, that should be your first clue. And you're going to see little representations of this. So with 3 vials, 300 milligrams is your first dose of amiodarone. Now, if each of the 3 is 150, that's 450, right? Well, what do you think your max dose is of amiodarone? It's 450. Do we really need to worry about that max dose? Well, remember the half-life of amiodarone is 24 hours. So we really don't need to, yes, you can go to 450 if you feel like you want to down the road, but as long as you do the initial 300 milligrams of amiodarone, we're good with that. So shock, shock, epi, shock, amiodarone. So you do the amiodarone, and then all of a sudden, 2 minutes is up. Let's check a pulse. There is no pulse. But guess what? On the monitor, you're going to see some type of rhythm, or you may see asystole. Guess what? PEA and asystole, they're all treated the same, right? So we either have pulseless electrical activity, or we have asystole, which is more or less a confirmation of death these days. However, working the patient, all right, I want you to get back onto CPR, and now the only drug we're going to give is epinephrine. And again, we're repeating that every 3 to 5 minutes. There is no max dose. Okay, so now we're in PEA or asystole. So what can we talk about as a group? Hey, how about the H's and T's? What actually caused this? All right, so let's go through some H's and T's, all right? Hypovolemia. Well, what can you do for that? Let's go ahead and hang some fluids, or possibly blood, but let's hang some fluids. Let's give them a fluid challenge, okay? So let's go through the list. Hypovolemia, hypoxia. What can we do with that? We can intubate, we can bag them better, we can reposition, okay? Hydrogen ion, acidosis. We can give bicarb. Bicarb is 1 milliequivalent per kilogram, so that could be done for acidosis. Hypo or hyper K. So if they're hyper K or hypo K, you can treat that however you would treat it. So maybe you want to hang a banana drip. That's just a joke. So then we also have, okay, let's go through tension pneumothorax. We're going to do a chest decompression. So for a chest decompression between the second and third rib, over the top of the third rib, midline of the clavicle, right? Over the top of the third rib, and then we're going to insert a needle in, and we're going to let the air out. That's a chest decompression. So from there, tamponade, what can we do for that? We can do a pericardial centesis. So we're going to have a really long needle on a syringe where we can aspirate blood. We go to the right of the xiphoid process. We insert until we see a spike on the monitor, and that's a pericardial centesis. And then we'll withdraw some blood. Okay, so we also have toxins where we can give Narcan and thrombosis. There's not a whole lot we can do for a coronary or pulmonary thrombosis in the ACLS setting directly. If we get them back and we can confirm a pulmonary or coronary thrombosis, then we can send them for further treatment from there. So, but really we're going to concentrate on the stuff we can fix now. So the 6 of you will concentrate on those H's and T's. You'll talk amongst yourselves, and then your instructor will just say, pick one and treat it, or treat hypovolemia. And you'll say, all right, we'll do a fluid challenge. So PEA Asystole, we're only doing CPR. We're only giving epi every 3 to 5 minutes, and we're going to talk about our H's and T's. So then finally, what do we have? We have ROSC. 2 minutes is up. Check for a stop CPR. Let's check for a pulse. We check for a pulse, and we have a pulse. Wow, we got him back. Isn't that cool? So the first thing you want to know if you got a pulse is, what kind of blood pressure does the person have? So let's go ahead and get some vitals. Where are we at on the monitor? Now, your instructor is going to say, what do we call this? And you're going to say, this is ROSC, return of spontaneous circulation. ROSC. And also remember, ACLS teaches that if you get a spike in your capnography, that could be a sign of ROSC, and you need to be checking for a pulse and things like that. So in ROSC, there are a few things you're going to need to say. All right, so your instructor is probably going to say, tell me about ROSC. Okay, so if they're unconscious, we're going to want to intubate them. If they're unconscious, we're going to want to induce targeted temperature management. And remember, between 32, 36 degrees Celsius for 24 to 48 hours, right? Now, if they're responsive, we're not going to intubate. If they're responsive, we're not going to do targeted temperature management, or hypothermia, also called. So again, as the lead, you're going to say, this is ROSC. So if they're unconscious, I want you to intubate. Let's go ahead and initiate targeted temperature management. What is my vital signs? Your instructor is going to say 110/70 with a heart rate of, you'll see the monitor right there. And you'll see the little monitor on there, the screen of what you're looking at. Then you'll also finish up, all right, what do you want to keep the pulse oximetry at? You want to keep the pulse ox at 94% or greater. You want the capnography between 35 and 45, or you could say above 40, whichever you want to say. All right, you want labs, you want a 12-lead EKG, and you want to get them the heck out of there, wherever they need to be. So now we're going to move them out of the ER or whatever environment they're at, and that's going to be the end of your Megacode. So with that said, we'll give you the example, and this is what we expect. This is all it's going to be. There's going to be no more, no less, no tricks. And we truly, truly do wish you the best of luck, and we hope this helps you. Have a good day.
I need monitor, O2, vitals, and IV established. Let's examine the patient. What's going on today, sir?
Okay, I have the monitor on.
Patient's on O2.
I have IV access.
What are my vitals? BP is 70/30, and he's having palpitations, and I have unstable tachycardia. Let's prepare to synchronize cardiovert the patient at 100 joules. Patient's lost consciousness. Let's check for a pulse.
There is no pulse.
Okay, the patient is in VFib. Let's charge the monitor to 200 joules, and when you're ready, let's shock the patient.
Okay, charging to 200 joules. Everybody clear. Shocking.
Okay, number 1, I want you to start compressions. Number 2, I want you to breathe for the patient. Number 3, I need you on the monitor. Number 4, I need you on meds. And number 5, I need you to record.
Okay, I'm starting compressions.
Okay, I'll grab a bag valve mask and I'll breathe for the patient.
Okay, I'll be on monitor. Okay, I'll do meds.
Okay, I'll record. How's the airway?
The airway is patent with good chest rise.
Okay, stop CPR, check for a pulse.
There is no pulse.
Okay, the patient is in VFib. Okay, let's charge the monitor to 200 joules, and when you're ready, let's shock the patient.
Okay, charging to 200 joules. Everybody clear. Shocking.
Okay, I want you to switch and begin CPR.
Okay, I'm starting compressions.
Okay, let's give the patient 1 milligram of epi.
Okay, 1 milligram of epinephrine administered.
Okay, stop CPR, check for a pulse.
There is no pulse.
Okay, the patient is in VFib. Let's charge the monitor to 200 joules, and when you're ready, let's shock the patient.
Okay, charging to 200 joules. Everybody clear. Shocking.
Okay, I want you to switch and begin CPR.
Okay, I'm starting compressions. Let's give the patient 300 milligrams of amiodarone. Okay, 300 milligrams of amiodarone administered.
Okay, stop CPR, check for a pulse.
There is no pulse.
The patient is in PEA. Okay, begin CPR. Let's give another 1 milligram of epi. And let's go over H's and T's.
Okay, I'm starting compressions. Okay, 1 milligram of epinephrine administered.
Let's intubate. Okay, stop CPR, check for a pulse.
We have a pulse.
Okay, great, we have ROSC. Okay, that is a normal sinus rhythm. Okay, let's get some vitals. Is the patient conscious? Let's go ahead and start hypothermia. I need labs. I want to maintain the pulse ox above 94%. I want the capnography between 35 and 45.